Good afternoon, good morning. This is Ken Wells from the Psychiatry Department, and it's my great honor to introduce our speaker today, Dr. Jürgen Unützer, MD, MPH, MA. Jürgen has been a friend, a colleague, a mentee, and a mentor of mine over many years. He has made a great difference in how psychiatry and primary care address mental health issues. He developed evidence basis and implementation and dissemination strategies and mechanisms for collaborative care, and helped lead policy change nationally for insurance support for collaborative care. He was a geriatric psychiatry fellow here at UCLA and trained in medicine at Vanderbilt, public policy at the University of Chicago, primary care psychiatry fellowship and public health services at University of Washington, where he also trained with and collaborated with the great Wayne Caton, the founder of collaborative care, particularly in psychiatry. He is a professor and chair of psychiatry and behavioral sciences at the University of Washington, directs the Garvey Institute for Brain Health Solutions at the University of Washington Medicine, and has appointments in public health departments for health systems and public health and global health. He founded the AIM Center for Advancing Integrated Mental Health Solutions in primary care, psychiatry, and beyond. And he led the development of IMPACT for evidence-based integrated care for depression, widely used across the US and worldwide. He was senior scientific advisor to the World Health Organization, advisor to the President's New Freedom Commission on Mental Health, and he's on the board of the Archstone Foundation. He has received multiple awards, not surprisingly, in psychiatry, geriatric, psychosomatic medicine, health services, and is a key change maker in services, science, and policy for mental health. A truly amazing individual. On a personal note, he played key roles in my early studies, such as Partners in Care, and over a period of more than 10 years, we collaborated on 17 papers and are collaborating on one now. And it's been such a great experience for me to learn from him, as we all will today. Here now is Dr. Jürgen Unützer.
Well, good morning, everybody. And thank you so much to Ken for this lovely introduction. I was just reflecting on the fact that I think Ken and I first met in a room on the seafloor of the NPI building about 34 years ago. And it's been just wonderful to learn from him for so many years and to get a chance to work together. And it's wonderful for me to be here and share with you today at this Grand Rounds meeting. So thank you for that lovely invitation. All right. So I'm going to talk a little bit about what we can do to try to leverage what psychiatrists do to try to improve the health at a population level. A little bit of disclosure. So as Ken mentioned, my day job is I chair the Department of Psychiatry at the University of Washington. I still do research that's supported by grants and contracts, and this concept of better integrating mental health and the rest of healthcare. I don't do any paid work for pharmaceutical or device manufacturers. I don't think I have any other conflicts for this presentation today. So a little bit about where I'm from. I work for an organization called UW Medicine. And that is a large academic healthcare system built around the University of Washington School of Medicine. One of the things that's unique about us is we are the only allopathic medical school with a psychiatry department for a 5-state region in the Pacific Northwest that covers about 27% of the US landmass. And that's relevant because, as you can imagine, that's an area that's largely very rural. And most of the people living in that part of the world have never seen a psychiatrist and will probably never see a psychiatrist, but they still live with serious mental health and addiction problems. So I think that creates a really important context for much of the work that we have done in our department there. A little bit about our department. We're a large department. We have about 1,350 faculty and staff. We work in about a dozen hospitals in Western Washington, around Seattle, but we have also programs in Idaho, in Montana. We have a very large psychiatry residency program. In fact, we have, I think, now the largest psychiatry residency program in the US. As everybody, we all used to work in hospitals and buildings, and now probably about a third of us are working from home. That's why I put the picture of the person with the little cat on the top of the screen. And that's a real change, even what we're doing right now. I'm used to sitting in the big NPI auditorium, and now we're here in a small room and everybody's on Zoom. So it's a brave new world, and we're all trying to figure out how that is going to work. All right, what do? We provide the whole range of crisis care and immediate care. We staff, our department staffs the county hospital in Seattle. And we also provide longer-term care. We have a brand new Center for Behavioral Health and Learning that I'll speak a little bit more about later on. We provide a lot of regional consultation through this 5-state region that we serve. We have a pretty mature research program, and we partner in care with colleagues at the VA, at Seattle Children's Hospital, at the Fred Hutchinson Cancer Center. We really enjoy all of that work. So just a little bit about what's the challenge that we're all kind of taking on. And you all know this, so I'm not going to do this whole slide for you. I think what we have increasingly learned since the 30-some years that I trained in psychiatry, that mental illness and substance use really are responsible for almost a quarter of all health-related disability worldwide. In fact, the data is now pretty solid that, in terms of things that disable you from a health perspective, mental illness and substance use are causing 5 times more disability than either diabetes or heart disease, and 15 times more than cancer. Now, you might say, how is this possible? Cancer is a terrible illness. It can even kill people. One of the big differences is that for most of us, if we have to deal with cancer in our lives, it'll come at us sort of in the later half of our life, or even very late, and then it can be, very disabling. But sometimes we've had a pretty rich life. Whereas with mental health and substance use problems, half of us will struggle with these things by the time we're 14 years old, and 75% of us will be affected by the time we're 24 years old. And so from a lifetime perspective, the cumulative burden is really, really enormous. You all know this, so I don't need to tell you this. So I'm going to keep going. So just a little bit about clinical epidemiology. So what do we know about how people with mental health and addiction problems get care? So if on this slide are all the people who are living today with a diagnosable mental health or addiction problem. So that could be all the people in the United States. This could be all the people in LA. This could be all the people in, that UCLA Health serves. If that's your denominator, how many of them, and they all have a diagnosable mental health or addiction problem, how many of them do you think will see a psychiatrist sometime in the next 12 months? Anybody? Anybody here in the room want to make a guess? Yeah. 10. Okay. So you're spot on. 12% of people who live with a mental health condition, today will see a psychiatrist sometime in the next 12 months. Now you might say, okay, there's a lot more to mental health care than psychiatry. There are psychologists and social workers and a whole host of different therapists. So if we take a very broad definition of getting mental health care, and we include everybody who's got some kind of formal training to help somebody with a mental health or addiction problem, including, say, for example, pastoral counseling, you get to 20%, so 1 out of 5 people. If you include our colleagues in primary care there, when people get surveyed, they'll say 40% of them will say, I got some kind of care for a mental health or an addiction problem from a primary care provider in the last 12 months. And that is where much of our work has focused. you might say this is the glass is half empty. I think the glass is half full, so that's an opportunity. And I think Ken and I and others have really worked in that space for a good 30 plus years. Now, the glass is half empty because after all of this, 6 out of 10 people who are living with a diagnosable mental health problem today will not see anybody and you get any kind of formal health care in the next 12 months. And this has been repeated every decade. Somebody does a very large epidemiologic survey and looks at this, and it really hasn't changed very much. Now, if you think about the fact that, I just said that there's 15 times more health-related disability that comes from mental health and addiction problems than from cancer. What if this was cancer? What if we said 6 out of 10 people who are living with a diagnosed cancer today won't see anybody who's got any kind of formal training to help you with cancer in the next 12 months? We'd find that totally unacceptable, right? But that's reality. That's really where we still are. So that's, I think, the challenge we still have. And when you dig a little into what are the problems in access to care, actually psychiatrists are a big part of it. 50% of us do not accept any form of health insurance. So we're the only medical specialty, where that is the case. And even if you do have insurance, and people increasingly have better insurance for mental health care, the average wait time to see somebody if you're in a crisis is just about a month. Now, if you had any other health crisis, you wouldn't find it acceptable to say, come see me in a month. And our colleagues in primary care know this. Every time people get surveyed in primary care about access to specialty care for their patients, we're sort of at the bottom of the list. So getting good help for a patient of yours who's struggling with a mental health or addiction problem is a huge challenge for people in primary care. So a couple of years ago, we said, we had a work in progress meeting in our research group, and we got into this little exercise here. And I said, so what did I learn in my psychiatry residency? We learned something called the 50-minute hour. Actually, it was a cute little book written, I think, called the 50-minute hour. And so what do you do in that 50-minute hour? You meet a patient and you establish a relationship, and you take a history, and you try to establish a treatment plan, and then you try to wrap up your session because you need 10 minutes to write a note, maybe go to the bathroom, maybe have a cup of coffee, and then you do another one of these 50-minute hours. So that's kind of what we learned. It's very, very important, and I still feel like our residents need to learn how to do a really good 50-minute hour. But we said, how well does this scale? So we made a little thought experiment. We said, what if we make a very conservative assumption? That would be that 3% of the population on any given day would benefit from seeing a psychiatrist for 1 hour once a month. And we said, if we take all the psychiatrists practicing in the United States, and they're working 40 hours a week, they don't take a lot of vacation, and those are all the hours that are available. So how many minutes would we have for somebody who's living with a mental health problem? And it turns out if you're living in Los Angeles or Seattle or some other urban area, we have about 6 minutes for you. If you're living in a rural part of the United States, it's 1.5 minutes. If you're living in India, it's about 20 seconds. If you're living in parts of Africa, it's about 3 or 4 seconds. So the whole notion here is this model of, doing really good 50-minute hours doesn't scale terribly well. And we could argue about the numbers, but I think the concept is pretty straightforward. And there's plenty of good data that says, there's federal data. Each state has data on what the shortages are when it comes to psychiatrists, psychologists, and other trained mental health professionals. In our state, in Washington, for example, we have 39 counties, and about half of them don't have a single psychiatrist, psychologist, or social worker. So really nobody in the entire county has got any formal training in mental health care. And so all I've done so far for the first 10 minutes is told you about a whole bunch of problems. So now, what do we do to try to close some of these gaps? And so here are some of the strategies that we've explored, and I'm going to try to give a few examples of over the last decade or two. So the first thing, I think we could all agree, we could all use more mental health professionals. So we should train, and not just train, but also retain in the workforce more mental health professionals. And so one of the things we've done in our department, we've built very, very large training programs. We have over 100 psychiatry residents, for example, in our department. But we also need to work smarter. So when we have produced a psychiatrist, a clinical psychologist, a clinical social worker, how do we work smarter? How do we leverage that person to try to have a bigger impact at a population level? And so there's a couple of different strategies. One of them is technology. So telemental health can make you portable. You can go to places where there might not be a psychiatrist. It doesn't multiply you necessarily. You're just moving services from one area to another area. Then, how about others? What if we collaborated with others? What if we worked with people in schools? What if we worked with people in primary care, in community-based organization? A lot of what we focused on is exploring different ways of doing that, and I'll show some examples of that. And then the other thing that I think we have increasingly recognized and focused on is we need to focus much further upstream. So if we wait, just because the things that we're talking about come at people so early, so if we wait until somebody presents, in their 30s in a psychotic state at our county hospital, we have probably missed a lot of opportunities to help somebody earlier on. So in our department, we've gone all the way upstream. We have built a very large program focused on perinatal mental health care. So how do I help a person before they're even born? And I'll say a few things about that. That sounds a little crazy, but I'll try to make a case for that. So this is a slide that just makes the point, and I'm not going to go through all of the details here. It takes a long time to train somebody. So if you want to solve the problems that we're talking about by training more people, it takes a minimum of 12 years to train a psychiatrist, about the same amount of time to train a psychologist. It takes a long time. It's a big investment. It's an important investment, but it takes a long, long time. So what we have been thinking about is we can't just solve this problem with doctoral level mental health providers. How do we think in a more broad way about who is actually part of the behavioral health workforce? So, there are psychiatrists, there are psychiatric advanced practitioners, so nurse practitioners, physician assistants that specialize in psychiatry, and we've actually invested in our department in training programs that train folks like that. There are people who are licensed to independently practice psychotherapy, psychologists, a whole range of licensed therapists. Those are the kind of things that we have traditionally trained in our departments, but now we're spending a lot of time thinking about who all else could be part of the mental health workforce if we supported them, enabled them properly. So what about primary care providers? What about other medical specialists? What about people who primarily see themselves in the social services business? What about people who are in law enforcement? What about people whose primary focus is on supported housing? They all are in touch with people who are living with mental health and addiction problems. What would they need to really become part of the behavioral health workforce? What about patients and family members? We built a big program in our department over the last year called the FACTS program, Family and Caregiver Training Program. So when a person gets admitted to one of our inpatient units, say with a psychotic episode, maybe it's a first or second admission, the parents might bring the patient or a spouse might bring the patient, and they will drop them off with us, and we will try to provide them a really good course of care on an inpatient unit. And at some point, the patient is well enough to go back home, and they'll come and pick them up, and they say, what do we do now? And so what I sort of realize is we might be providing really good care, but we haven't done anything for these families. Just what if we said to that family, we're a university-based clinical healthcare system. What do we do in a university? We teach people how to do things. What if you came here and while your loved one is in care with us, we're going to offer you a whole bunch of education and training on how to work with somebody who's living with a psychotic illness. And that's the concept of just saying, how can we really broaden this workforce? And so that's something we've invested in a pretty significant way. Just an example. The other thing we've done is we've recognized that at the University of Washington, we're just like UCLA, very large public university. We have a very large undergraduate program, almost 50,000 students. The number one major in our undergraduate program is psychology. And our undergraduate psychology students, they don't learn anything that we would sort of consider clinically relevant. They learn about normal psychology and abnormal psychology and developmental psychology. And interesting things that happens when you do things with college students in a laboratory. But they're actually pretty hungry to say, could I learn how to work with a person who's struggling? So we're looking at, we have a global health program in our department that does really cool, creative things. For example, they might go to a war-torn country like Sudan or the Democratic Republic of Congo, and there's a lot of people who've experienced serious trauma, post-traumatic stress disorder, and they will provide to high school trained people who have no mental health training in evidence-based, exposure-based psychotherapies that you can offer in a group setting that turn out to be tremendously effective for PTSD. They'll publish that in the Lancet or in the New England Journal of Medicine. And then I think to myself, if we can do this in the Sudan, why aren't we doing this in the United States? Why do we say somebody has to have an MD or a PhD to be able to do pretty straightforward exposure-based psychotherapy? So we've gotten some philanthropic support and now some state support to offer to the undergraduate students in 6 public universities in the state of Washington, clinical training alongside their undergraduate degree, where they get a certificate as a behavioral health support specialist. They can offer evidence-based psychotherapy under the supervision of a psychologist or a psychiatrist. So these are just examples of saying we got to sort of broaden the workforce. One of the things that we have spent a lot of time on is this concept that Ken mentioned, which is to say, what about those 40% of people who say, I got some help for my mental health problem in primary care? What do we do to help our colleagues in primary care do this? And this is one slide that tells a long story of many, many projects that Ken and my mentor, Wayne Caton, and others engaged in some 30 years ago to sort of say, how do we do this? And I think where we've landed is to say the primary care practice and the primary care physician has the ability to recognize somebody who's struggling with depression. They can start treatments, but they need some help. So the recipe that we cooked up, the way we like to do collaborative care, is we partner the primary care physician and the patient with somebody in the practice we call a mental health care manager. That could be a nurse, a social worker, a licensed therapist, and we give that team a psychiatric consultant, a psychiatrist who backs up the team and consults to them, but doesn't see all the patients. And we teach the team how to measure how well the patient is doing. Just like if you were treating their diabetes, you're measuring their diabetes. If we're treating their depression, we're measuring at every visit, how is their depression doing? We teach them a number of evidence-based brief psychotherapies that are on this slide, because just writing a prescription for an antidepressant doesn't do it for most of our patients. And what you actually don't get in primary care, you get a lot of prescriptions, but you don't get good psychotherapy. So we teach them how to do brief evidence-based psychotherapy right in the primary care practice. We put everybody on a registry tool, and the psychiatrist doesn't see all the patients, but their job is to comment on every single patient in this practice who is not improving. And that's how we know how to focus that time of the psychiatrist. How well does this work? This is one slide from a big study we did. We did that while I was here working with Ken at UCLA, called the Impact Study, where we took about 2,000 older adults in 18 primary care clinics in 8 states. And we randomly assigned them to getting usual primary care or getting this kind of care that I just articulated. And we looked a year out and we said, what's the likelihood that people have a significant improvement in their depression? So a 50% or greater improvement in their depression a year later. What we found is with this kind of a collaborative care approach, you roughly double the likelihood that a person gets better from the perspective of their depression. And it was a very robust finding. There were some variations across sites, but at every single place we tried this, we did better with this approach than with just telling a doctor, your patient is depressed, maybe you should start them on an antidepressant. We found some other interesting things. We found, for example, when we looked 4 years out, that 4 years later, when we looked at the total healthcare utilization, the total healthcare spend that patients in the study had, the people who had gotten the collaborative care actually had significant reductions in their total healthcare spending. So from a perspective of a return on investment, for every dollar we spent on this collaborative care approach, we saw $6.50 in reduced healthcare spending over the next 4 years. That is actually something that was interesting, because when that came out, the Wall Street Journal wrote a paper about this. And I would say we got more attention from this tiny little paper, which actually this little article in the Wall Street Journal. It wasn't actually very well done than I've ever gotten from anything we've put into JAMA or the New England Journal of Medicine or the Lancet. So if you want to get people's attention, see if you can get a reporter at the Wall Street Journal to write about your work. We then, when I moved back up to Seattle a little over 20 years ago, we said, you know, who else could benefit from this? And so we sort of struggled with this notion of, we had done work with older adults who were depressed. We said, what if we go all the way upstream? What if we try to use this kind of an approach with people who are pregnant, who are getting care from a community health clinic? And so we had a wonderful partnership with King County, that's the county around Seattle, where we tried this model of care. We served 2,500 low-income mothers who had depression, who were treated in one of 14 community health clinics. This was a group that was quite severely depressed. 34% of the patients had active thoughts of suicide at the time that we put them into this project. And this one was not a randomized controlled trial, but we had a very good sample of women who were getting care in these clinics before we implemented this program, and then afterwards. And what we are showing here is a survival analysis. And just to explain this, what we're looking here is how many weeks go by until a certain proportion of the women in care have a 50% or greater reduction in their PHQ-9 depression score. So the blue curve was the curve of the women that we measured before we implemented this collaborative care model. And you can see it took about a year, 60-some weeks, until half of the women in care actually showed a significant improvement in their depression scores. You know, after we implemented the collaborative care model, we shifted that curve way over to the left. So now it's about 9 weeks until half of the women in care in the clinics are experiencing a significant improvement in their depression. And that difference, you know, when you're seriously depressed during pregnancy or during a postpartum period, is a very, very important difference. There are others who have replicated these studies. The Mayo Clinic did their own study. They were not involved in any of that original work. And they said, look, we have really great care. So they actually implemented this in some of their primary care clinics, and they published a paper that said, you know, when they looked at it, you know, they could reduce the time it took for the average patient getting depression care in a Mayo Clinic primary care site from, you know, well over a year to 86 days. So I think the lesson here is treatments for depression do work, but you have to do them, and you have to do them right, and you have to change when people are not improving. You can't just write a prescription and sit on it and see, let's see what happens. A couple of years ago, we said, all right, this is good. This seems to work for depression. People started challenging us. They started saying, what about people who are much more seriously ill? What about people who have bipolar disorder? What about people who have, you know, trauma along with their mood disorder? So John Fortney and I did a trial funded by PCORI that enrolled about 1,000 patients with bipolar disorder and or post-traumatic stress disorder. And that study was a little bit different because we recognized these are people who are more challenging, more complex. So what we tested there is we compared two models of care. We said, on the one hand, on the bottom of this slide, we're going to give people an enhanced version of collaborative care, where we're going to have the primary care provider working with the patient. We will have a care manager in the practice, and we'll have a psychiatric consultant. And the difference here is that psychiatric consultant was asked to see every patient at the beginning of the project, because we wanted to make sure we got the diagnosis right. You know, it's not that easy to make a good diagnosis of bipolar disorder. And the comparator was, what if we gave everybody specialty care? So the primary care doctor and the patient need to just refer. And the referral was psychiatry and psychology. So we referred to a psychiatrist who was university-based and a psychologist who had training in psychotherapy. And the difference here was these were all done by telehealth because we were doing this study in some very rural settings. So these are some of the sites that work with us in 3 states, in Washington, in Arkansas, and in Michigan. And the design, we randomly assigned 1,004 patients. Half of them got telepsychiatry collaborative care, and the other ones got referral to specialty care. But it was all specialty care delivered by telehealth. And if you look at it, we kind of got what we had hoped to do. If you look at the number of encounters people had in a typical year, on the collaborative care arm, patients had a lot more encounters in the primary care setting. They all had one visit with a psychiatrist, and then they had probably about 10, roughly on average, 10 encounters with one of the care managers in the clinic. The specialty care referral, a couple of visits, 3 visits with a psychiatrist, about 4 visits with a psychologist, and then ongoing primary care with their primary care provider. All these patients were still always being treated in primary care as well. If you looked at our primary outcome, because we weren't really chasing just one condition, we picked as the primary outcome for this study mental health functioning. This is the mental health component summary score from the SF-12. And what you'll note is at our baseline, we had a group of patients in this study that was functioning very, very poorly. So a score in the 20s is an incredibly low mental health functioning score. That's several standard deviations below what you would expect for an average person. But what we did see is we saw really significant improvements in people's mental health functioning. And we really didn't see any difference between the 2 arms. So I think what we took away from is good treatment works. You just have to make sure it really happens. We also saw similar findings when we looked at people's symptoms. We saw really significant reductions in symptom scores for PTSD. We saw a significant improvement in the likelihood that people with bipolar disorder stayed in a euthymic state. This was a bit of a surprising finding. All of these patients, many of them were already on some form of psychotropic medications at the beginning of the study. So we used some side effect scales, and we actually saw reductions in side effects, in the course of treatment. And I think that was just to say, if you manage the medications more, appropriately, you actually can improve that as well. I'm gonna shift gears a little bit, after doing a lot of work where we primarily focused on what can we do treating people in primary care, we started becoming more and more familiar with the limitations of what you can actually accomplish in a busy primary care doctor's office. We said, look, people are going to spend a bunch of time in primary care, but they're not living in a clinic. They're living at home. They're living in a community. And I think, over the last decade or two, many of us have become more and more familiar with some of the very important social determinants of health, that are contributing to all of the mental health and addiction problems that our patients have. And we said, what if we went outside of primary care? What if we went and said, what if we partnered a primary care clinic that can do collaborative care with a community-based organization that can actually do something working with the patient in the community where they live? We got some really nice support from a Southern California-based foundation called the Archstone Foundation, and we did a study called the Care Partner Study. In that study, we worked with 8 clinics, all in California, 8 primary care clinics that we had trained up in collaborative care. And each of these clinics found 1 or more community-based organizations to partner with. And they would literally sort of say, how do we share the care for depressed patients? What can we do in the clinic? What can we do in the community? And the way the sharing happened varied a little bit from site to site. But the basic innovation was we took the standard collaborative care model at the top and we added a community-based organization as a partner. And so, like I said, it varied a little bit about what people did in the community. Some of them focused mostly on outreach and screening and diagnosis. Some of them focused more on actual treatment in the community. So providing a psychotherapy, for example, in the patient's home instead of in the clinic. And here's some data from this project. We enrolled about 800 depressed older adults. Some of them were quite elderly. 20% of them were 80 years and older. The patient demographics really represented a California population. The largest group were white Latino, followed by white non-Latino, but we also had African American and some mixed race patients in this study. We looked at 2 things. We looked at, say, how do people actually use this kind of a thing when you offer it to them? And what we found is people actually make quite good use of this offer, which is a shared offer where you get some of your care in primary care and some of it is in the community. 89% had 2 or more contacts with somebody in the clinic, and 75% had at least 3 contacts with somebody who was working for the community-based organization, the community-based partner. In some cases, we also had family members involved in the care, and 55% of the time, a family member actually had 3 or more contacts with some of the treatment team. And about 75% of the patients had 1 or more direct psychiatric consultations, but all of the patients had their care reviewed and discussed by one of the team psychiatrists. One of the things that happened to us in the middle of this project is COVID came. And you can imagine we had a bunch of older adults living in California, really scared about what was going to happen if they're going into a clinic or if somebody comes into their home. So we had to really retool this project. We sort of reinvented some of what we were doing with our older adult clients. We developed this approach called Stay Connected, where we really worked hard to say, what can we do to help people stay connected during the period of COVID? And then, about a year out, we looked at clinical outcomes for everybody. And what we essentially found is that we had a moderately to severely depressed group of patients in this project, and about 70% of them had a pretty substantial improvement in their depression scores a year out. And that's actually really encouraging because that's significantly better than what we saw in the original impact trial with a similar aged population. And so that made us believe that maybe when you add a community-based partner, you really can go beyond what's possible to achieve just in a clinic. I presented a whole bunch of research. I'm going to shift gears now. Research is good, and one of my lessons has been in life, if you get enough money from a grant, you can give people money and you can create pretty much any reality you want to. But when you start having to say to people, use your own money, I don't have any money for you to do the stuff that I did in research, it becomes very, very, very challenging. So it's taken me, we've been doing, Wayne, Caton, and I have been doing research on collaborative care at the University of Washington for a couple of decades. And it's taken us longer to try to get our healthcare system to actually implement this kind of work in our real world healthcare system. But we've been pretty successful. So over the last 15 years or so, we now have every single one of the University of Washington affiliated primary care programs has a pretty robust behavioral health integration program. That's what we call collaborative care in our healthcare system. And we've learned a lot from doing this in the real world. We also, a couple of years back, we established a really wonderful partnership with a managed Medicaid program in our state. This is a Medicaid program that treats mostly low-income low-income patients in community health clinics throughout our state. Much of our state is rural. And so we trained people in 100 primary care clinics, a little more than 100 primary care clinics throughout our state, how to offer this collaborative care. And we used our registry tool and we tracked the outcomes of 50,000 patients in depression care. And the outcomes we're finding vary a little bit. And I published a paper about this, but on average, they come quite close to what we saw in our randomized controlled trials. So it's actually been really interesting to learn from a very large scale real world implementations. If I talk to the psychiatrists in our department who work in these programs, I hear a lot of things, but there's 2 themes of what they say to me. They say, this is different from me being in the office and seeing a handful of patients. I am helping so many more people than I used to see when I was just doing, 1 or 2 or 3 or 4 half days in clinic. And every one of those days I'd see a handful of patients. But when I give a half a day to a primary care clinic where they're managing a whole panel of patients, I can really focus my energy on the people who are not getting well. I can have very brief encounters with patients. Sometimes I might have an encounter, the doctor calls me and says, I tried an antidepressant, it's not working. The patient is a little bit more agitated. And I'm like, well, I wonder if this is a bipolar patient. And then I might take 10, 15 minutes to see that person on telehealth. And I don't need to do a whole hour. I don't need a 15-minute hour. I can ask some very focused questions to kind of reassure myself, is this bipolar depression or is this really depression? And so you can focus your time and use your time a little bit differently. And you have a whole team that works with you. And one of my favorite saying is, none of us is as smart as all of us. And I'm always smarter practicing with a primary care doctor and a care manager than I am by myself. That's one of the other things I've learned. The second thing I hear from our psychiatrists, they like this work. The ones who like this work and who stick with it, they say, this is a great way to teach because we're consulting every week to these primary care doctors that are taking care of really sick patients. And these are really smart doctors. Psychiatrists aren't always the brightest of all the doctors. These are some super smart, sorry, I didn't want to offend you there, but these are some really smart physicians. And when you teach them about what to do, when a patient doesn't get well on a particular drug, or, when their psychology makes it difficult for them to stay engaged in treatment, they are soaking this up like a sponge, and they're going to use it on their next 10 patients. So there's a tremendous multiplier effect if you do this right. We recognized this about 2 decades ago, and we sort of said, now research is really good and we can publish more papers, but people have a hard time implementing this stuff in the real world. So we started a program called the AIMS Center at the University of Washington, which stands for Advancing Integrated Mental Health Solutions. It's just a resource that helps people implement, and we have just celebrated the 20th birthday. If you like to learn about how we do this, what we do, our website is on this slide. We've written a couple of books about how to do this. We have invested in a pretty serious way to try to develop collaborative care teams across our state. There is only one county in our state. It's a tiny county, Garfield County, that doesn't have a team of collaborative care that's trained by us at this point. We provide an eco-style telehealth program where once a week, primary care doctors that are part of this network call in. We've provided about 13 or 14,000 hours of CME, and we discussed cases with them. We had a grant with the Center for Medicare and Medicaid Services and the American Psychiatric Association, where we trained 3,500 psychiatrists in how to do this kind of consultative work. It's not something you learn in residency. It's a different kind of skill, and you've got to learn how to do it. And I'll wrap up on a couple of things just more local for us. So about 5 years ago, we strengthened our partnership with our own state, with the state of Washington. This is our governor, Governor Inslee, who made a serious investment in trying to strengthen our mental health system. And as a university, we partnered with them in 3 key things. The first one is workforce development. We increased the size of our residency. We increased the size of our child psychiatry program. We added residency training for nurse practitioners and physician assistants in psychiatry, and we developed this program that I mentioned a little earlier to train bachelor's level people to function as part of a healthcare team. We also stood up a 24/7 telepsychiatry consultation program. I'll mention something about that in just a minute. And then finally, the state invested $250 million in helping us build a new facility on our campus called the Center for Behavioral Health and Learning. And I'll say a little bit about that. This is something that just opened its doors a couple of months ago. It's on our northwest campus of the University of Washington Medical Center. It's attached to a medical surgical hospital. And I think it's a really, really fascinating psychiatric facility. We have 150 beds. 100 of them are psychiatry inpatient beds. 50 of these beds are beds that are providing medical surgical care for patients who have psychiatric needs. I think one of the most neglected things we have in our field is we provide good specialty care, but people who are living with mental health and addiction problems also have serious unrecognized and undertreated medical and surgical needs. And so we decided to have 50 beds that are really focused on that population. We had a wonderful philanthropic gift as part of a $50 million gift to build a neuroscience program in our department. And that gift included giving us the ability to develop some really great state-of-the-art neuromodulation treatments that we offer in this facility. And we host in this facility our statewide consultation program. So in a Neuromodulation Institute, we offer, existing standard treatments such as TMS and ECT. We have our own dedicated space to do that. So we're not doing it in a surgical suite, in a PACI. We actually have dedicated psychiatry space, and we're offering these treatments in one space. So it's not like you got to go to one place for ECT, and if that's not working, you might go to another place for TMS or maybe vagal nerve stimulation. We can offer the whole range of treatments in one suite where we can really focus on what is the best for this patient. And if they're not getting better with one modality, we don't have to send them away. We can say, let's try something else. I'll wrap up on this. This is our statewide consultation line. So one of the things we offered our state When we started this partnership a couple years ago, I said there are so many places in the state where there are healthcare professionals, nurses, doctors, pharmacists, who are encountering patients with mental health or addiction needs that are really challenging, and they don't quite know what to do. And I said, what if I could offer them that any time of the day, 24/7, 365 days a year, they can pick up the phone and talk to a psychiatrist at the University of Washington? And people said, that's crazy. And I told this to people in my department that that's crazy, but that's exactly what we did. So we actually have a line like this where anybody anywhere in the state can pick up the phone and talk to one of our psychiatrists in real time. We do a lot of these. It's a very, very busy program. The state supports us very well to do it. One of the things we learned early on in this work is there are some populations where the needs are very specific. So for example, if you're helping advise on how to treat a pregnant woman who has got bipolar disorder and type 1 diabetes and is on lithium, that's not something that most your general psychiatrists are going to be super comfortable with. So we have a little subline that focuses on perinatal psychiatry. We have 8 perinatal psychiatrists in our department that can help provide us that kind of service. I just gave you a very quick whirlwind tour of a whole bunch of strategies we've tried over the last decade to just say, when you have a psychiatrist, when you're in an area where there aren't ever going to be enough psychiatrists, what are all the things we could try to leverage the skill that a psychiatrist has to try to help reach more people in need? So I think we got about 10 minutes left. So I'm going to wrap up in here. My email's on here. I'm happy to hear from any of you. And I know that I went fast through this. But any thoughts, any questions you have? Ken, I think you're going to come up and help us with questions.
Yeah. So if you're online, you can pop a question in the Q&A. We'll start with the room. And I have to, so they can hear, I have to repeat your question, or one of the two of us has to repeat it so they can hear it, just FYI. So please feel free to put into Q&A and we'll be monitoring that too. Okay? So thank you. Yay. Let's do a little applause. All right. Steve.
Yeah. Jürgen, wonderful talk, and it's great to see you. Could you talk a little bit more about disseminating these models to the SMI population? I do consulting throughout the VA, for example, and I think they believe in it, but so much of the care of the most seriously ill people is going out to advanced practice nurses who really don't have the training in SMI, and they don't have, and the access to psychiatrists is terrible. So I mean, what kind of problems have you faced in these large public systems and being able to disseminate this model?
So disseminating the model to SMI, and Steve gave the example of VA. Go ahead.
Yeah, I think that is a real challenge, and I wouldn't want to overpromise there, because I feel like people who live with really serious and persistent illness, it's very hard to manage them, say, in a primary care setting. So I feel like we have models, that have been around for a long time. A good ACT model, a good PAC model. They're expensive and they have to be well resourced, but they can make a huge difference. And in those kind of models, you have to build a team where everybody, knows where their competency ends and where they're going to get support. And I feel like in a team like that, if you have good psychiatry support, a nurse practitioner can learn a lot pretty quickly. But you really do need to sort of provide that psychiatry support. And if you ask somebody who doesn't have quite the skills to manage a complicated population like that, they'll easily get overwhelmed and they'll walk away from it. You really have to have their back. You have to be there. You have to be able to say, you can call me anytime if you get stuck with a challenging problem. I think that's also true in primary care. So when we started taking patients who have bipolar disorder and said to primary care doctors, you should manage them, they were pretty freaked out, because some of these patients are really, really challenging. And we said, we're going to be there for you. We might be more present. We might be able to help you. You can call us anytime you want to. So I feel like you have to take the amount of support you offer to the severity of the problem. So with an SMI population, I don't think you can just say a nurse could do this or nurse practitioners can do this on their own. That's trying to do it on the cheap, and I think it doesn't really pay off.
Okay, next question.
So maybe 17 years ago, I had the good fortune of being in a small meeting with an international health psychologist. So a lot of European health psychologists. And one of the things that struck me was that the clinical outcomes, or the main outcomes that they were aiming towards, was really role functioning, like things like return to work. And there was a lot of discussion about how we tend to focus on symptoms here, right? PHQ-9 and so on.
Yep.
So I'm curious just to hear a little bit of your thoughts about where you think that's landing now, many years later.
So the question is, what are we learning about role functioning, return to work and so forth, rather than symptoms per se?
Yeah, I think it's a really good point. I mean, I think if you look at clinical trials in our field, they do like to still think about does the whatever the one target symptom gets better, but our patients don't really care what their PHQ-9 score is, right? They want to be able to do things they want to be able to do. So a couple of thoughts on this. One of them is in the way we teach the care now, we will usually say we're going to use this scale or that scale to see how your disease is doing. So we would, in diabetes, you still want to know what their A1C is, but you might also want to know, are they able to do the things they want to do, right? So what I like to teach is to say, you're going to say, we're treating depression, we're going to keep track of this depression score to see if that's getting better, but let's set a personal goal for you. And that personal goal could be something very personal. And we can scale on that too. There's a concept called goal attainment scaling, where you say, if this treatment works as well as it possibly could, if we hit a home run here, what does that look like? You know, and they might say, I want to be able to do X, or I want to be able to be married and have children, or I want to be able to see my grandchildren. And you say, let's scale on that. If we hit a 0 on that, what's that like? If we hit a 10 out of 10 on that, what's that like? And so you can actually do very, very good goal-focused kind of treatment, but you might still want to keep track of what's their blood pressure, what's their diabetes, you know, what's their depression score, right? So I don't think it's an either or. I think you really want to do both.
Great, thank you.
Yes.
Great talk. It's really kind of a magnificent articulation of the systematic collaborative care model. Can you give a little bit of a sense of the current status of larger developments in collaborative care? Is there any sort of movement towards a nationwide form of collaborative care? What would that take? Obviously, we have the VA, but in general, I'm curious about that.
So the question is, what about the national scope and what kind of dissemination is occurring nationally?
Yeah. So one of the naive things that I learned after we finished the big impact trial, we published it in JAMA within 3 months of finishing the study. We were very proud. It got a lot of attention. And then I realized nobody's going to be able to do this because this is stuff that without a grant, you can't pay for it. That's something that should have been blatantly obvious to all of us going into it. But we didn't really think about that. You know, we're a bunch of doctors, researchers, right? So we spent, and I didn't mention this, but we spent about a decade working with the Center for Medicare and Medicaid Services to create CPT billing codes, where primary care practices can bill for the doctor visit, but they can also bill for providing evidence-based collaborative care treatment. And it's been interesting. So there is the whole talk about when you innovate in medicine, it takes 17 years until something comes from a paper to practice. I think when insurers put out a new billing code, it takes at least 17 years until practices figure out, oh, this is real. This is actually something I could bill for. Even in our own healthcare system, we now have Medicare, Washington State, Medicaid, and virtually all of the commercial insurance companies in Washington would pay for these billing codes, but it's taken practices a long time to kind of figure this out, to figure out how to bill it, to make sure they don't get audited. All of that stuff, you know, these implementation challenges aren't just clinical, they're also business implementation challenges. But I think having figured out a way to actually get paid for that care is that's crucial. It makes sense, right? Nobody wants to do anything for free, right?
Okay, I'm going to read out 3 comments that came in through the Q&A, and you can figure out which of those you want to respond to.
Okay.
To what extent do payers cover non-traditional forms of treatment, teleconsultation, where the MD only provides a few minutes of their time? That's number 1. 2, can you please discuss more about some of the institutions' resistance that occurred in implementation of successful research results? You just did a little bit of that. 3, do you partner with chaplains, religious organizations to help patients? Okay,
those are great question. I'm gonna see if I can remember all 3 of them by the time I get done, but you can help me out.
There they are right there.
So
for the first.
Okay, the non-traditional treatment. Yeah. So if you're a psychiatrist and you want to do this kind of work, you want to get paid for doing this kind of work. There are really two formulas at this point. One of them is you go work for the VA or for Kaiser and you say, what's your collaborative care look like? And you might be able to do that kind of work, right? Those are capitated healthcare systems. Some of them have figured out, actually, this isn't a bad way to use a psychiatrist. That's one path. The other path is you work with a healthcare organization that's gotten good at building these codes. And you're not actually billing. It's one of the nicer things, I'm not a biggest fan of billing after every single thing I do. So the primary care practice is billing a monthly code for providing the collaborative care service. And if you are providing consultation to that team, they'll buy a bunch of your time. So the vast majority of our psychiatrists who are doing this work, we contract for 4 or 8 hours of their time. Where just somebody just buys a piece of FTE from me. And the way they cover those costs is they get, a piece of that reimbursement that the primary care practice is charged to the health insurance system. So that's the billing question.
Institutional resistance.
Yeah, what is the resistance? Okay, people don't like change. It's as simple as that. So if you think about it, as healthcare professionals, I've talked to my colleagues in clinical psychology. They spend their entire careers on a model that helps explain how one patient changes one simple healthcare behavior, right? You want to get a patient to change smoking or to do something, right? That's one patient, one behavior. And it's super complicated. And maybe the best models were like 30–40% of the variance in what it took to get that to happen is explained. Now think about what's implementing a thing like this in a complicated organization that's multiple people changing a very complex behavior. It's really, really hard to do that. There is a whole field now. Ken and I learned something called health services research. Now I think the word is implementation and dissemination research. There's some overlaps. But I think it's really, really challenging. People don't want to make change, and you'll find resistance in all kinds of places. Some of the biggest resistance, frankly, in my experiences, come from psychiatrists, who are saying, but I learned how to do the 50-minute hour. What are they doing? Wanting to come here and do this other weird thing. That's not real psychiatry. And if your psychiatrist in your healthcare system pushes back against something like this, nobody will touch it. So that's an example of resistance.
Yeah.
But there are others.
There are
and
others,
then
many.
Chaplains.
Yeah.
Could you work with chaplains? That's a really great question. I know Ken has, worked in that space quite a bit.
Yeah.
How
How about your Archstone project? Did
Yeah.
you work with chaplains?
Yeah, so we talked about that. So, it depends a little bit on the organization. There are some of the community-based organizations that we worked with that are religious organizations. And they had to really think about, how do we use a chaplain or a priest? And you can have some really fascinating discussions between psychiatrists and chaplains and priests and rabbis about, who owns the depression. I think when you really get down to it, we all realize this is a really challenging thing. None of us have all the answers. And if you can find a way to work together, I think it can be super productive. But the cultures are pretty different. So it requires some really significant trust building and ongoing work. But I think it's interesting and it's worth it.
Yeah, we did co-training of, barbershops and faith-based organizations and primary care and so forth in the collaborative care model. Yeah. Anyway, that's another issue.
So speaking back to the billing, I may have missed it, but have you been able to figure out the paraprofessional, billing in Washington, and how's that?
It's all bundled into the collaborative care billing code.
Okay.
So if we have a social worker or a medical assistant or a nurse who is in the practice, who is providing some of that care, we can bundle that into that monthly billing code.
Yeah.
So not everybody cuts their own little bill. It's really it's a bundle payment.
Got it. So California has recently legislated, right, billing reimbursement for community health workers, essentially, in a range of health domains. Could be for anything. And I was super excited about this for lots of behavioral health challenges. Talked to a public policy colleague in Department of Public Health, and he went on about all the details of the structural barriers, institutional barriers, about how you actually set up those billing codes. Because that's more of an individual fee for service model, right? I'm the CHW, I provide the service, I report it, And then my organization gets $28 or something. per-
Yeah, and it might cost them more to cut the bill than
Yeah.
than what they're getting, so then it's not worthwhile, right?
Right.
So,
Yeah, and now what they're doing is contracting directly with the community health worker agencies
With a specific
for,
separate. yeah.
for the CYBHI, for the youth initiative.
so one of the things we learned in the Archstone project, in the Partners in Care project, was we trained a group of community health workers in an organization called El Sol that's out in Riverside, to go into patients' homes and to provide really good behavioral activation treatment for patients who are depressed. And we had better clinical outcomes with that group than we've had with anything I've ever done in research. I didn't believe the data, it was so good. We actually went down there and visited with them and checked it out, and it was just fabulous. You know, these were community health workers, not a bachelor's degree, no formal training, but they did learn how to do really good evidence-based behavioral activation. And they would go into patients' home, and instead of just having a nice supportive conversation, they'd say, hey, let's work on something you can do between now and next time when I come back here. And it was amazing how effective that was. So I think we are quite convinced that it can happen, but the payment stuff will take some time to really catch up.
Yep. All right.
Awesome.
Yay.
Thank you.
Thank you. Great job. Thanks for joining, everyone.